So hello everyone, thank you all very much for attending this press briefing today. My name is Dr. Anne-Marie Baird and I am actually the immediate past chair of the ISLC Communications Committee, and I'm also a Senior Research Fellow in Trinity College, Dublin in Ireland. I'm also very active in the patient advocacy community, and I'm the current president of Lung Cancer Europe. So in this press briefing this afternoon, or this evening, or this morning, wherever you may be, we will be discussing several presentations from this year's World Conference on Lung Cancer programme. So these will cover mesothelioma, the impact of COVID-19. There's also going to be a talk relating to disparities, and that's within mesothelioma, because we can't forget that those people that are impacted by mesothelioma can also face disparities. It's not just those that are living with lung cancer. And we'll also discuss around depression, anxiety and distress experienced by those living with thoracic malignancies during the pandemic. So it's quite a broad number of topics for our presentations this afternoon. So of course, also very importantly, we have with us today our patient advocate, and for today this is Dr. Shani Shilo. Dr. Shilo is the founder and CEO of the Israeli Lung Cancer Foundation. Her husband was diagnosed in July 2011 with stage 4 lung cancer at the age of 43. And during the journey they experienced together, Dr. Shilo decided to establish the first patient organization in the field of lung cancer in Israel. And huge congratulations to Dr. Shilo for achieving that. They're doing great things through the organization. Dr. Shilo will be providing comments on the discussed presentations that we will go through, and we'll be doing this through a patient advocate lens, which is so very important. I would ask you to hold your questions for the presenters and for Dr. Shilo until the end of the briefing, at which time you can ask questions live or via the chat function. So without further ado, given our packed program, I would like to introduce our first presenter, and that's Dr. Boris Sepisi, who is presenting instead of Dr. Anslow. Dr. Sepisi is an associate professor in the Department of Thoracic and Cardiovascular Surgery at the University of Texas MD Anderson Cancer Center. Dr. Sepisi's clinical focus is on the surgical therapies of thoracic and upper gastrointestinal malignancies, and his research interests focus on therapy outcomes, immunotherapy, and translational research in esophageal and lung cancers as well. So Dr. Sepisi will be presenting a trial of neoadjuvant cisplatin Pemetrexed with atezolizumab in combination and maintenance for resectable pleural mesothelioma. So I'll pass over to you, Dr. Sepisi.
Thank you very much. So let me share my screen here to make sure that you do you see my presentation now?
Yes, perfect. If you'd like to put it in presentation mode.
Yes. Let me just switch the slides here. Do you see?
Perfect.
Okay.
Yeah, thank you so much.
Thank you very much again for the opportunity to present this trial. This is a trial called S1619, SWOG trial of the neoadjuvant cisplatin and Pemetrexed plus Autozozumab in resectable pleural mesothelioma, and I would like to thank Enso for the opportunity I'm presenting on her behalf. In terms of my disclosures, I do serve occasionally as a consultant and on the steering committees for some clinical trials that are sponsored by some of these companies here, BMS, Lilly, and Genentech, and also I have received some speakers fee from AstraZeneca and Medscape. I don't have a specific conflict of interest for this particular presentation or this study that we will present. In terms of the background, as we all know, malignant mesothelioma is a deadly disease and it's an extremely difficult disease to treat. And it can present in very heterogeneous situations, either with localized disease within the chest cavity, or it can present also as a metastatic disease. When we speak about disease of mesothelioma that is potentially surgically resectable, that is the patient population that we sort of consider potentially curable, although we know that recurrences occur. The median survival in patients who undergo multimodality therapy that includes surgery range in different studies between 17 and 25 months. We have since then learned that mesothelioma is an immunogenic disease, and with the advent and increasing use of immunotherapy, certainly immunotherapy is also now being tested as part of mesothelioma treatment. And when this study came about, this was before the Checkmate 743 trial came out with nivolumab and ipilimumab showing benefit, especially in biphasic and sarcomatoid mesothelioma. The aim of this study was really to test chemotherapy plus immunotherapy in surgically resectable mesothelioma based on the fact that these are occasionally immunogenic tumors. They express PD-L1 expression, the PD-L1, which is associated with worse outcomes. So the study concept was patients were evaluated for resectability by surgeons who deal with mesothelioma. These patients should not have undergone any other prior therapy, such as chemotherapy. And then plan was to administer cisplatin and pemetrexed, which was considered, has been considered the standard of care up until now. With the administration of Autozozumab, then patients would undergo either pleurectomy, decortication, or extrapleural pneumonectomy with an optional adjuvant treatment with radiation, and then maintenance Autozozumab subsequently. So the primary endpoint was to evaluate safety and feasibility. This was really one of the first, essentially the first trial combining chemotherapy with immunotherapy followed by surgery. And the plan was to accrue 24 evaluable patients. The initial idea was that there would be 12 of them would undergo extrapleural pneumonectomy versus pleurectomy decortication. However, the field has moved more towards performing pleurectomy decortications because of their safety and apparent oncological equipoise with extrapleural pneumonectomy. And so the regimen would be considered to be safe and tolerable if patients did not have either grade 4 or 5 toxicity. And then the analysis was planned to be done separately in patients receiving pleurectomy decortication versus extrapleural pneumonectomy. And it was anticipated that a total of 28 patients would need to be registered for 24 eligible patients. So this is our consort diagram. 28 eligible patients were evaluated between November 2017 and May 2020. 25 of them received at least 2 cycles of chemotherapy plus Autozozumab. 18 of them underwent surgery and 15 received maintenance therapy. So as you can see over here, there were some reasons of why patients were ineligible, and then surgery at registration, there were 19 patients. As mentioned before, vast majority of these patients received pleurectomy decortication instead of extrapleural pneumonectomy, and there are still 3 patients receiving maintenance therapy. In terms of patients' demographics, median age was 68 years, mainly predominant male population over here. And again, pleurectomy decortication because of its safety and the understanding within the field that this is perhaps the right operation for with maximum cytoreduction. Majority underwent pleurectomy decortication. So here are the preliminary outcomes, since there are still patients who are receiving adjuvant therapy. So 21 patients completed neoadjuvant therapy, but 7 of them did not proceed to resection, 2 of them due to toxicity, 4 due to disease progression, and 1 of them due to death that was associated with sepsis. 18 patients with stable disease or partial response proceeded to surgical resection. 17 of them received pleurectomy decortication, and 1 had EPP. And 16 patients registered to receive maintenance Autozozumab for 1 year. And as mentioned before, 3 patients remain ongoing on maintenance Autozozumab therapy. In terms of toxicity for this regimen, as you can see, it was rare for the grade 4 and 5 toxicities over here. So I'll just essentially skip through this, but it seemed to be reasonably tolerated regimen in this patient population. Now, these are some preliminary survival results, which at this point seem rather encouraging, although the median follow-up is not same as in some of the previous trials. But when we look at overall survival, at this point, the overall survival, the median survival has not been reached, and progression-free survival, the median progression-free survival is at least 18 months. So some of these results are comparable to perhaps slightly better to historical cohorts, but we will have to complete the trial and complete the adequate follow-up to be able to make any conclusions from this regimen. So what have we learned so far from this in terms of preliminary take-home message? So 4 cycles of neoadjuvant cisplatin, Pemetrexed, and Autozozumab was successfully delivered in 21 eligible and evaluable patients. 18 patients proceeded to surgical resection, and 16 patients were able to proceed with maintenance atezolizumab. There was no delay in treatment adverse events. At this point, there was no new safety signal for this regimen for the cisplatin pemetrexed atezolizumab maintenance therapy. 3 patients are still undergoing this therapy, and preliminary efficacy has median progression-free survival of 18 months, and overall survival has not been reached. And as always with mesothelioma, this trial highlights the challenging nature of the neoadjuvant therapy because of the heterogeneity of the disease, as well as how patients react, as well as the difficult and complex surgical therapy. However, I think this is a step forward in terms of complex treatment of mesothelioma. So that's what I have. Thank you very much.
Thank you very much, Dr. Sepsi, for that overview. And I'm sure, like everyone here in the mesothelioma space, we await the full trial outcome and follow-up from your study. So thank you very, very much for presenting. So next up is actually myself. So I will just share my screen with you. So hopefully everyone can see that okay. So it was really my great pleasure to present today on behalf of the IASLC Communications Committee. We undertook a study looking at the global impact of COVID-19 on telehealth and care for persons with thoracic cancers. So here are my disclosures. None of these relate to the presentation that I'm giving today. So we're all very acutely aware that the COVID-19 pandemic has resulted in huge challenges across the healthcare system and in healthcare delivery right across the globe. And a lot of people are still facing these challenges today as we get more and more waves of the COVID-19 pandemic. We came from a situation where face-to-face consultation was really the exception rather than the norm. And many people faced significant barriers to accessing the care that they usually would have taken. And this was across countries and within regions. So telehealth was really employed then to trying to engage and monitor people remotely and to, of course, try and provide a system where there would be continuity of care. So the aims of this study were really twofold. One was to assess the use of telehealth during the pandemic itself. And the second was to try to understand the impact on thoracic cancer care, and this was from the perspective of healthcare professionals. There were other studies which looked at this from the perspectives of patients and advocates, so this one dealt specifically from healthcare professional standpoint. So the methods for this study, the IASLC Communications Committee developed an English language survey, and this was administered using Qualtrics software. It was quite a short survey, and it concentrated on, as I said, the use of telemedicine and the impact of the pandemic on lung cancer and mesothelioma care. The survey was widely disseminated via the IASLC and a number of other organizations, and this was really through multiple modalities. Global regions were classified based on the IASLC criteria, with regional differences compared with chi-squared and Fisher's exact tests. So here I just want to give you an overview of the participant characteristics. So we had 141 who took part in this survey. The majority of our participants were male. We're in the 41 to 60 years old age bracket. We're based at an academic centre, and the primary specialty of those that participated in the survey were medical oncologists. In terms of this global spread, the majority of our participants came from the US and Canada, which is 38%, and this was followed by Europe at 29% and then Asia at 15%, with rest of world and Latin America making up about 18% overall of our participants. So one of our first questions was just a general one, and it was around the use of telemedicine and telehealth. And 63% of all of those who participated used telehealth for the very first time in their practice. The form of telemedicine varied, and it was mainly either phone call or a mix, with some using phone calls with third-party platforms. And when we asked about ranking of the platforms, as you can see here, it really varied, but the video via e-medical record was that was most preferred. However, when you look at our participants here, although the phone call was that which was most widely used, it was the least preferred method of telehealth utilization. So this is something that really needs to be addressed when we look to develop kind of hybrid delivery of care in the coming months and years. When we looked at some of the barriers that people faced while implementing telehealth within their practice, it really came down to lack of resources. This was both at a patient level and an institutional level, and of course, some experienced regulatory limitations as well. When we asked about advantages, we had a number of predetermined choices that people could pick from. And the top three for both providers and patients are given here in percentages as well. So really the advantages were around the continuity of care given to those impacted by thoracic malignancies. Also maintaining contact with patients was seen as a very great advantage, and access to people living in remote areas as well. So these were the three that ranked the top within our survey. When we looked at telehealth disadvantages, again, the three that ranked top did so for providers and for patients. And this was around lack of human interaction. Of course, lack of internet access is also an issue for a lot of people, and a lack of tech knowledge as well, because we can't just automatically assume that everybody has access to smartphones or so on and are able to use them. The other thing that came up within the top three was missing the informal aspects of face-to-face visits within the clinic. And when we looked at both the advantages and disadvantages across the IASLC geographical areas, we didn't find any significant differences by region. These were the things that came out irrespective of the region that the participant came from. We then asked a number of general questions regarding the suitability of telehealth in the care pathway. So the majority of our participants felt that patients were receptive to telehealth. However, when we asked some questions around disparities, this was really split amongst our participants, with some feeling that it would be increased, some feeling decreased, and some feeling that would be no change. Again, this is something that we have to be very aware of as we look to incorporate telehealth within the pathways, and to really ensure that it isn't increasing disparities faced with people living with thoracic malignancies. Most people felt that telehealth was most suitable for surveillance, so at the surveillance point of the care pathway. However, over half, at 55%, felt that telehealth was not suitable at any point of the care pathway. So again, this is something that we really need to look into and try and figure out ways to make sure that it is used in the most suitable manner. Overall, 48% of our participants felt that telehealth is here to stay, and quite a lot of them felt that this would be in a hybrid model with a mix of face-to-face visits as well as telehealth consultations as well. When we looked at COVID-19 impacts on the care pathway, we asked around 4 broad areas: diagnostics, care, research, and clinical trials. And I'm just showing you the top 2 from each of those 4 categories that were chosen. So in terms of diagnostics, it was really that there was fewer people presenting into centres. And then it was felt that there was significant delays coming from primary healthcare services into the hospital setting as well. In terms of care in general, the 2 things that ranked most highly were around delays in accessing clinical trials and delays in accessing surgery as well. Talking about clinical trials, specifically, a large number of our participants felt that there was a reduction in the number of clinical trials that were offered, as well as a number of people being impacted by the halting or the stopping of current clinical trials at centres. In terms of research activities, it was felt that there was a decrease in activity going on, and those that would have had protected time to undertake research activities had the time reduced. And of course, this is also going to have a huge impact. We did ask a question around lung cancer screening as well. And for those who were in a centre where lung cancer screening was undertaken, the numbers coming through were also reduced. So the take-home message really from the survey the IASLC Communications Committee undertook is that with telehealth, there are a number of issues that exist with the use of it. And really, there needs to be the development of very clear guidelines around the use of telehealth to ensure that it enables the best delivery of care to people impacted by thoracic malignancies. In terms of COVID-19 and the impact on care, we have found, and it is of no surprise to anyone, that there are significant impacts on all parts of the pathway, from research right through to care, and this will result in poor outcomes for people living with this disease. So we really need to ensure that these are tackled appropriately so that we can overcome the negative impacts on the COVID-19 pandemic, because we know that there are fewer people presenting. We are already seeing poorer outcomes. So we need to make sure that the indirect impacts of COVID-19 are tackled and are done so as speedily as possible. And I'd just like to thank all of the Communications Committee for their input into this study. In particular, I'd like to mention Matt Smeltzer, Brendan Stiles, and I'd also like to give a huge shout out to Jan Mazzatti as well. So thank you very much. And with that, I will stop sharing my screen and we will move on to our next presentation. So our next presenter is Dr. Estela Mar Rodriguez. Dr. Rodriguez is an Associate Director of Community Outreach and a member of the Lung Cancer Site Disease Group of the NCI designated Sylvester Comprehensive Cancer Center at the University of Miami Miller School of Medicine. Dr. Rodriguez has a special interest in the early detection of lung cancer and developing programs to eradicate healthcare disparities. Dr. Rodriguez is going to talk to us about the socioeconomic disparities in access to treatment and survival and operable malignant pleural mesothelioma in the US. Over to you, Dr. Rodriguez.
Good morning. I am delighted to present our work from the University of Miami on socioeconomic disparities in access to treatment and survival in operable malignant pleural mesothelioma in the United States. These are my disclosures, but there's no conflicts of interest for this presentation. Malignant pleural mesothelioma is a rare disease with an overall poor prognosis despite multimodality treatment. There is limited data regarding the impact of disparities and access to care and patient socioeconomic status in outcomes. The goal of this study was to examine factors associated with patterns of care and overall survival among patients with operable malignant pleural mesothelioma by treatment access and patient socioeconomic characteristics. We identified 2,804 patients with potentially operable malignant pleural mesothelioma stage 1 to 3. Most of these patients were males, which mirrors the epidemiology of this disease. Looking at the surgical cases, most patients undergoing surgery were males of white race, with only 5.5 Hispanics and 4.7 Blacks in the general population. Patients that underwent surgery had better prognostic indicators like stage 1 or 2 or epithelial mesothelioma. And most patients undergoing surgery had private insurance or Medicare insurance. Very few patients were uninsured or had Medicaid in the range of 3.9%. What it was really important to note in terms of access is that most of the surgeries for malignant pleural mesothelioma are undertaken at academic centers and high volume facilities in metropolitan areas. We found that patients undergoing surgery were traveling a longer distance for their procedures. On a multivariable analysis, controlling for neighborhood socioeconomic status, insurance, education, comorbidity index, and facility type, there was no difference in overall survival. We did find, which has been found in other studies, that the predictors of poor overall survival for operable malignant pleural mesothelioma include advanced age and male gender. What are predictors of improved overall survival relate to access to treatment in addition to surgery. So patients undergoing surgery on top of chemotherapy had improved survival with a hazard ratio adjusted of 0.60, which is a 40% reduction in mortality. Also, patients undergoing multimodality therapy, including surgery, chemotherapy, and radiation, also had an advantage with a hazard ratio adjusted of 0.73. Also, the prolonged chemotherapy use in the adjuvant or neoadjuvant setting portended a better prognosis. When looking at income and mesothelioma survival, we found that although the patients at the lower income had worse survival, it was the patients in the third quartile who had the best overall survival with a 17% reduction overall mortality risk, which is actually was better than the patients at the highest quartile, more than 63,000. In conclusions, we found that patients with increased access to care, they were closer to facilities, had access to academic high volume centers, were more likely to have surgery, and very patients receiving surgical treatment came from rural areas. The receipt of adjuvant chemotherapy or multimodality therapy predicted better outcomes among surgical patients, controlling for patients' race, socioeconomic status, facility, and tumor characteristics. Some of the limitations of the studies were the selection bias included in the National Cancer Database where this patient's information was obtained, the lack of longitudinal treatment data and other clinical relevant outcomes, such as patient-related outcomes and social determinants of health like transportation, housing segregation, education, occupational exposures, and food access. There is also a small proportion of Blacks and Hispanics in this population, making it difficult to make comparisons regarding race and survival. I will say that the findings of this study suggest that patients without access to multidisciplinary care and chemotherapy at high volume academic facilities in the United States are being probably inappropriately undertreated for their disease due to lack of access. Our research does confirm that factors predicting better survival include younger age, female sex, and having access to care, which was facilitated by private insurance and Medicare insurance, with the best survival seen in the third quartile of income. The identification of this and other health disparities related to malignant mesothelioma will allow us to undergo future research and clinical guidelines and policies to decrease the burden that health disparities generate in the diagnosis, treatment, and prognosis of this disease. Thank you.
Thank you so much, Dr. Rodriguez. That was a fantastic presentation. And as you say, it's so important for us to be aware of disparities in care and access and the impacts that can have on our community. So thank you very, very much. Our next presenter is Dr. Oscar Arrieta. Since 2005, Dr. Arrieta has been the head of the Thoracic Oncology Unit and the Laboratory of Personalized Medicine at the National Institute of Cancer in Mexico City. Additionally, Dr. Arrieta is a faculty member of the National Autonomous University of Mexico with more than 25 years of experience. Currently, he is a medical oncology and thoracic oncology professor and is the current IASLC regional representative for Mexico and South America. And Dr. Arrieta is going to present on depression, anxiety, and distress impact in patients with thoracic malignancies during the COVID-19 pandemic. So I'll pass over to you, Dr. Arrieta. Thank you very much.
Thank you. Thank you very much. I will share my slide.
If you just want to put them into presenter mode, Dr. Arrieta, brilliant. Thank you.
Thank you. I would like to thank the committee for the opportunity to share our results of the clinical and social impact of the COVID-19 in patients with lung cancer. This is my financial disclosure. And first, accumulated evidence indicates that the patient with lung cancer are vulnerable population in the to the COVID-19 complication. However, a delay in the treatment can negatively affect patient prognosis. This study evaluate the impact of the COVID-19 in terms of the anxiety and the depression in patients without cancer, as well as this association with delay or suspension of the therapy. Additionally, we evaluated the impact in terms of the prognostic of outcomes of the change of the oncologic treatment and COVID suspension in this patient. This cohort study includes patients with thoracic neoplasms within a single institution between March 2020 and February 2021. All variables of interest were extracted from the electronic medical records. During this period, the depression, anxiety, and stress was evaluated by the scale -21, was applied to evaluate and identify more common psychological disorders. Here we can see the change of the treatment during the COVID-19 pandemic. Among study participants, 24% had adjustment in the treatment due to the pandemic. The principal reasons to change the treatment was they avoid the exposure to the COVID-19, and other is the suspicion of the COVID infection. This is around 35% and 10% of the patient respectively. The most common kind of the change of the treatment was delayed more than 7 days in 42% of the patient, and the dose modification in 10% of the patient. The treatment interruption was observed in the 37% of the all patient. We can see here the association with the depression. We found high depression in the 18% of the patient, anxiety in the 30% of the patient, and stress in 18% of the patient. Of course, the depression and the stress was associated with the treatment delayed, with a very high risk to the change of the treatment in this patient with depression and stress. And we can see here the effect of the prognosis-free survival and the overall survival in the patient with treatment modification related with the COVID-19. Of course, we found a very important effect in the prognostic-free survival and the overall survival, and reduce the prognostic of the patient. On the other hand, we found also the patient that with a suspicion of the COVID-19 impact also in the prognostic-free survival, in the overall survival. Of course, we found a fatality rate around the 28% of the patient in all patients with the thoracic malignicities, and of course the patient with infection with the diagnosis of the COVID-19 affect in the overall survival compared to the patient without the diagnosis of the COVID-19 mortality. The complete results of this study was published in the Oncologist, the journal The Oncologist, and we can find all results. Maybe here the most important is the change in the health quality due to the COVID-19 demand make worse patient prognostic due to considerably delayed in the treatment. Cancer treatment cannot stop even during the COVID-19 pandemic. Change with favor a safe environment for the patient in oncology, in age oncology unit must be prioritized in order to continue offer the highest quality care, oncology care. Thank you very much.
Dr. Arietta, thank you so much for that presentation and huge congratulations on your publication. Well done to you and the team. That's fantastic to see.
Thank you.
So now that the more scientific presentations have come to an end, we are now importantly going to look to our patient advocate perspective. So I will now hand over to Dr. Schillo, who is going to do a short presentation of some of her thoughts on the data that she has seen presented here this afternoon. So over to you, Dr. Schillo.
Yeah, so thank you very much, everybody. I'll just share my presentation. Just a second. Okay.
And if you'd like to just put it in presentation mode.
Yes, yes, here.
Yeah, perfect. Thank you so much, Dr.
Okay.
Schillo. Perfect.
Okay, so thank you very much. Hi, everybody. You know, I spoke with Dr. Anne-Marie Baird yesterday, and we know each other from the patient organization world. And COVID-19 has been also affecting, you know, us and our connections. And we really also, as patient organizations, we meet in different types of conferences like the World Lung, and you know, we share ideas and thoughts and projects. So we also miss very much the, you know, the face-to-face interaction. So we really hope that next year we can do this together. Okay, so these were very interesting presentations, and two of them regarded mesothelioma. And if we look at the first presentation by Dr. Sepsi, a trial of neoadjuvant cisplatin Pemetrexed with Autozozumab in combination and maintenance for resectable pleural mesothelioma. So we heard and we know that mesothelioma is a very aggressive disease. And in this study, and it's still a very big unmet need. And although numbers are decreasing in the world for mesothelioma, it's still a disease we need to take care of. And it can arise not only from asbestos, although main risk factor is asbestos. So what, from the patient and the family perspective, point of view, and as I say, you know, there's the patient with lung cancer, but there are the caregivers and the family who accompany him and who are part of this lung cancer family. And when we speak about the patient, we also speak about the caregiver. So what was very good to hear from this study was that the treatment did not cause side effects who were bigger than grade 3. And that is a very, very positive thing, because today what we see in lung cancer, and these are really fantastic years, so we see that we can today treat lung cancer and have targeted therapies, etc. But the main question, okay, so we now elongated life, but we need, the question is, what is the quality of life? You know, the years to live a good life, and not only more years of life. So this was a very good result from this study, and from the point of view of patients and their caregivers. And also another thing that was good to hear from the study, that, like we said, mesothelioma is a big unmet need, and we need more clinical trials, we need more research, and we need also more advocates for mesothelioma. And maybe also Dr. Baird will agree with me when I think of the colleagues, my colleagues, patient advocates from around the world, and that some of them are patients of lung cancer and some of them are caregivers like myself. My husband was diagnosed with lung cancer 10 years ago when he was 43, a never smoker. So I became a caregiver because of what happened to us, a caregiver and a patient advocate. So, but with all the patient advocates I know, I don't really know a patient advocate who had mesothelioma, who has mesothelioma, or is the caregiver of somebody with mesothelioma. So I think we have to, empower them to rise and to become advocates. So if we look at the second article that was presented by Dr. Bird about the global impact of COVID-19 on telemedicine and care for persons with thoracic cancers. So, I mean, pandemics are never good, but if there was something good about this pandemic, was it made us adjust to new means of communication, and we needed to find solutions, for the visits, especially the visits that there's no need for actual treatment. I mean, for like IV treatment, etc. And what happened is that centers adopted and implemented telehealth communication, which was, I think, really acceptable by patients and caregivers, and also by the oncologists. So what we have to ensure is that, first of all, telecommunication will be here to stay, and we will use it more and more with pandemic or without pandemic. Of course, the face-to-face meeting is very, very important, but we will learn how to use the telecommunication and telemedicine, and we have to think, first of all, how we ensure that patients can use it, that they have the digital means to use telemedicine and telecommunication, and also that they have the know-how to use telemedicine, because we must not forget that lung cancer, most patients of lung cancer are older patients. Many countries are not like, we have countries where there are more rural areas, with people who have less digitation. So we need to help them, and give them means for performing and using telemedicine. So this is really, I think, a fascinating thing. If there's something about patients and caregivers which is a big burden, is the regular communication with the team, okay, with the oncologist or with the nurse, because some doctors will give their phone number, some doctors will not, some will give an email, some will not. So when we saw what the telemedicine did, what we did in COVID-19, I hope that we can take this thing and use it and develop it, so we can maybe improve also the day-to-day communication. Okay, so when we need something, like when a patient has a side effect and he needs an answer, it's not easy to get the answer. So I think this is something, Anne-Marie, to think, how to better develop this daily communication, and not just at the visit. And the third article was also about the mesothelioma. Again, like I said, it's a really big unmet need. And when I read the study and heard the study, I saw that there was a mentioning of the health insurance status, but we really need to think about the low-income people and the low-income families. How can we help them, and how can we ensure that they get the best treatment options with no connection to their location? And we always think of solutions, how to bring the patient to the center. But when I was listening to the lecture, I was thinking, we always think how to bring the family, but maybe we should bring the center to the family. Like, we as patient advocates, we always think about things, how to address, how to use, how to change. So I thought of something like, if we had from big centers, like a mission squad, that goes out once a month to to areas who are who don't have the big centers, or who go out this squad to the little centers, to teach the oncologists and the teams. So maybe this is like a twist of thought of how to improve treatment for people with mesothelioma, but of course for anybody who has lung cancer, but they are, you know, in the less, you know, big city areas. And of course, it's important in it's significant in big countries, you know, like US or South America and many other big countries. Israel is a small country. In Israel, it is less the problem, because in 4 hours you can get everywhere. But I think in very big countries in Europe, all over the world, we need to think about it. And a very interesting study. And the last study about depression, anxiety, and distress impact in patients with thoracic malignancies during COVID-19. So this was very interesting. And we know that COVID-19 affected everybody. I mean, even people without a disease, you know, felt anxious and depressed. And this whole era is very difficult. So can we imagine, you know, the effect of the pandemic with people who have like a terrible disease, a heart disease like lung cancer? And especially, I think also when we talked about COVID-19, there was the beginning, like the first few months, who were very, you know, they didn't really know what to do, right? Everything was a bit like, what should we do? Should we go to the doctor, or should we stay at home? Should we skip the treatment, or should we stay at home? So it took a few months until I think everybody, also the medical centers and the teams, understood how to manage this. But what we see here, that I mean that the people really had depression and other anxiety, etc. And the sad thing that this led to treatment suspension even, and this treatment suspension leads to death. So we really have to ensure that this will not happen. And I think this highlighted that the mental health condition of patients is of great importance. And even in regular times, we sometimes do not address it seriously enough. And it should be addressed because we see the results here. So I say, you know, I don't know, I think in the US it's also, or in other countries, you know, when the team sits to talk about the patient, right, about the case, and they call it a tumor board, right? And you know, when you say tumor, you treat the tumor, right? But no, we're treating a human being. So this team that sits and talks about the patient should be called the patient board, you know, and then you can address all the patient's aspects, including mental health. And we should take it seriously and help them. So this is like, this just emphasized again how the mental status is very important. And as a caregiver, I mean, the mental health of the caregivers and the families is important too, just because we are the ones who support the patient, you know. So we really need to think about the patient, but also look at the whole family and see how we can help them. Thank you very much. You know, come visit Israel, and I hope I see everybody in person next year. Thank you.
Thank you so much, Dr. Schiller. That was a great overview, and I completely appreciate your point that, you know, when clinicians and others are looking to treat someone impacted by lung cancer, that it has to be more of looking at the whole person and the impacts that not only the disease but the treatments can have as well. So thank you very much for that. And of course, the shout out for caregivers too, because they do tend to be forgotten in the midst of everything else. So we're going to open up for questions now, and there are a couple of questions in the box, but before we go to them, I just want to go back to Dr. Schiller just to ask, I think you might have a question or two that you want to ask one of the presenters, if you'd like to go first.
Sorry again.
I think I wanted to ask one of the presenters a question, if you would like to go first.
Yeah. The presenters, so just let me see what I wrote here. I had something here. I mean, I was a bit when I was reading, and hearing the articles, I want to address the mesothelioma issue. Like, so we are seeing a decrease in mesothelioma, right? I mean, among the years we see a decrease, but do you see, are there parts of the world or any places that there's an increase of mesothelioma, or is it something we should be concerned about, or is this really a disease that is going away from the world? Maybe the experts on mesothelioma.
I can take that. So, there is a lag between the exposure to asbestos and the actual development of disease that can be from 20 to 40 years. So since the laws that have decreased asbestos exposure in different countries have not all happened at the same time, there is still, in parts of the world like United States, the rates are going down, but parts of Eastern Europe, the rates are going up because we're still seeing that lag. But even in the United States, like we presented, even if the rates are going down, we're still not able to offer the best treatment to every patient. So we're missing patients who potentially have operable mesothelioma, which are presenting late, and they're not having access to the right multimodality therapy. And as we discuss new technologies like immunotherapy and neoadjuvant immunotherapy, or very exciting new developments on understanding the genetics of mesothelioma, we really have to ensure that patients have access to all that research and clinical trials to be able to have equity.
Dr. Schiller,
Thank
do you have anything else that you wanted to ask any of the presenters?
No, I think I addressed it in my summary. So.
Perfect. So we'll return to some of the questions in the chat. Now, some of them have been answered in the chat, but obviously that's not recorded. So for the purposes of this, I will go back and ask those questions. So Caroline Helwig from the ASCO Post had a question for Dr. Sepsi. Caroline, I don't know, would you like to ask your question in person, or do you want me to read it from the chat box?
You can just read it, Dr. Baird.
Okay, perfect. This is for our first presenter. So what is the median follow-up time? You say the results seem comparable to or a little bit better than historical controls. Can you elaborate? And without atezo in this regimen, what could you have expected in terms of progression-free survival and overall survival to be? So just trying to get a handle on how much the immunotherapy is adding. So that's Dr. Sepsi. Thank you.
And so, thank you very much about this. It's not that I want to walk back what I stated, but I do want to clarify a couple of things. Number one, there is no level 1 evidence for the treatment of what we consider surgically resectable mesothelioma. So the comparisons that I mentioned as an expert, sort of from the data, either from our institutions or from other institutions, are the data that I use in my brain to make some of these comments. Another comment I'd like to make is that this was a feasibility trial of chemotherapy plus Autozozumab. So phase 1 trial that was looking essentially at safety and feasibility. By no means there was a goal of this trial to make any kind of comparisons between chemotherapy and the regimen that has been used, so cisplatin plus Pemetrexed versus that plus Autozozumab. So this was, and this trial was not powered by any means to show the benefit of these drugs. And as I mentioned before, there's a tremendous heterogeneity in terms of treatment of mesothelioma that is where the surgical regimens are being used. There are people and institutions around the world, and even within the United States, where patients with what's considered surgically resectable mesothelioma undergo surgery up front without any neoadjuvant regimens. So when we make a comparison to these data that we have over here that we have not reached, for example, in overall survival. We have not reached median overall survival. And I don't necessarily have the exact number, but just looking at the Kaplan-Meier curves, it appears to me that the median follow-up may be around 20 months. But I want to be very careful about overstating some of these results until this trial is completed, until the results are analyzed. The results also need to be analyzed in patients with mesothelioma based on their nodal status, for example. I know that at MD Anderson, in patients who have N0, so they don't have any disease within the lymph nodes and are surgically treated with multimodality regimens, median survival is approximately 20 months. So again, I don't want to overstate the results. I think that this trial still needs to come to its conclusion to make its final comments about safety and feasibility. However, the preliminary results that I have presented, I think, sort of speak for themselves. It's going to take us a while to make advancements, I think, in terms of phase 3 trials and get new regimens. It took us at least 10 to 15 years to go from the regimen of chemotherapy plus Pemetrexed to nivolumab and ipilimumab in unresectable mesothelioma. That was the trial that was recently published within the last year that has basically established immunotherapy as a potential option for mesothelioma patients. So as was mentioned all day here, and I'm sorry for my long answer, mesothelioma is still extremely difficult disease to treat, and everything that was mentioned about participating on clinical trial, advocating for these patients, reaching out to people who are even outside of the main institutions to come to main institutions that do research and that specialize in these complex treatments. I think all of that would advance not only results, but also care for patients, as it was mentioned over here. So that's my long answer to that.
Thank you. That's very clear. Thank you.
Thank you so much for the question, Caroline, and thank you also, Dr. Sepsi. Shani, you have your hand up there. Do you have something you'd like to add to that?
Yes, I wanted to ask, and I admit that today I from you even I understand better mesothelioma. And should we, what I'm asking is, are we proactive enough in finding these patients, like, trying to early diagnose mesothelioma patients according maybe to to where asbestos was used or factories or something? Like, maybe we should be more proactive, as in terms of nationalities or municipalities, like to do something proactive to find them, to go to them and say them, let's check you.
Yeah, I'm not sure if anybody wants to take the answer for that, but that would be outstanding. You're essentially asking the same question like screening for colon cancer, or screening for breast cancer, screening for lung cancer. For lung cancer, we now know that in smokers in high-risk groups,
Right.
CT scan sort of helps. As was mentioned before, the problem with mesothelioma is this latent period that could range between 20 to 40 years. There's no good blood test or a biomarker that we can use. For example, for colon cancer, fecal blood test is a relatively cheap way of screening. For mesothelioma, it's usually diagnosed by thickening on the pleura on the CT scan. And so let's say somebody knows that they have been exposed to mesothelioma, let's say at age 20. Well, at what point do you then start scanning them? Is it going to be cost effective? Is it going to be, all these other epidemiological issues come to play? It's still a rather rare disease. In the United States, there's about 3,000 of cases of mesothelioma per year, versus, let's say 180 or 200,000 lung cancers. So I agree with you. I think we would have to be much more direct, for some of these, but it's not only people who are exposed. We see, for example, some mesothelioma in, let's say, in women or family members who are washing clothes of their husbands or family members who came in and were exposed to asbestos. That's a very tricky, on a population level, a very sort of a tricky issue, how to screen for mesothelioma and what would be the best test for it.
I would add that we do need to collect better occupational history and family history in our patients. And also what I think is important is that patients do have symptoms that they report for sometimes months and years before they're really taken seriously and addressed. Since there's not a clear association with smoking, a lot of these patients, they present with symptoms, they get misdiagnosed at outside facilities. And that is important for really to make sure that this level of care or multidisciplinary care and understanding of the pathology of mesothelioma is available widely for patients to get diagnosed early.
I think in Australia, they do have quite high numbers in Australia. And I know there are some regions that kind of keep registries, because there was a lot of talk about the third wave of mesothelioma in Australia, because a lot of the older houses would have asbestos materials in them, and they were seeing people who were doing kind of home renovations, not aware that there could be asbestos in their house, that this third wave was coming. So I think there is some stuff going on in Australia around that, but very good points from Dr. Shilo around trying to be better targeted. So I'll return to the chat box now. We have another question from Edward Sussman from MedPage Today. So Edward, I don't know, would you like to ask your question in person, or will I just read from the chat box? Up to you.
I think you can just read it. It's pretty straightforward.
Perfect. So this question was directed to myself about Dr. Sepsi's study, asking about putting in perspective how promising the study is for patients with mesothelioma and what needs to be done next before this treatment can gain traction. So I actually think in the previous reply that Dr. Sepsi had given, he has covered quite a lot of this. I mean, I think it was a small study. We would really need to see kind of the final outcomes from the study. It was a feasibility study before we can, you know, say a lot more concrete or make more concrete comments on it. One of the things that did strike me was that it was in resected mesothelioma cases. Now, I am not a mesothelioma expert or anything like that, but I would have thought that, you know, those that present with resectable mesothelioma are probably not the majority of cases that would be seen in clinic. So, you know, how appropriate it would be in the general population, or whether or not a study like this can be applied to those that maybe has already received some sort of treatment, or they're treatment naive, but they do not have resectable disease. So I think you probably need more work within this area, and then obviously different phases of clinical trials to see what the outcomes would be from there. So I don't know, Dr. Sepsi, if you would like to add anything further there to that.
No, that was again, very, very well said. We do classify, you know, as surgeons or people who work with the mesothelioma field, we do classify patients as potentially surgically resectable versus not. As you can see, there is some selection bias that is also factored into this. Again, this was not a randomized trial. The only thing I can say is that there are other ongoing trials that are also looking at other regimens, whether they are regimens that combined two different types of immunotherapies or single agent immunotherapy versus this was a chemotherapy plus immunotherapy, and people are starting to think about potentially combining low dose radiation with immunotherapy. So once again, all I can say that there is a significant amount of research that goes into mesothelioma. It would take us time to go through the phases of trials, but I would encourage every patient with mesothelioma to try to participate on a clinical trial and be evaluated at a center that has sort of the infrastructure to take care of these complex patients.
Yeah, thank you very much. And I know we are running slightly over time, but hopefully I might be allowed to ask Dr. Arietta a question, because we've talked an awful lot about mesothelioma during this session. And I just wanted to ask, during the study that you presented, it was quite interesting, the data you showed between males and females when it came to stress and anxiety, and that the percentages of females that experience stress and anxiety were so much higher than that of males. So I'm just wondering, would you have any comment on that, or did you see anything else? Now, I'm sure this is probably in your publication, so I do apologize. But did you see anything that sort of stood out as to why that is the case, or have you any thoughts around that as to the huge differences between both genders?
Thank you for your questions. Yes, we found an important difference between a statistical difference between the females versus the male. However, the most of the women have treatment with TKIs, and we found more effect in the change of the treatment in the men, specifically with the chemotherapy. So the reason that this association with the female, I don't know what is the reasons. However, it's very significant, the change of the treatment in the patient.
Yeah, it's very interesting to see that. Apologies, I think someone might have been trying to ask a question there. No? No, maybe it's just someone in the background. So given that we are nearly 10 minutes over time, and I'm sure there's a lot more questions that could be asked, but of course, please do keep up the discussion over social media and so on, because these areas that are covered today around, you can see the amount of discussion we've had around mesothelioma. Sometimes it's not given the voice that it truly deserves, and the issues around clinical trial options, disparities, and so on. And of course, as well, keeping it to the fore of our minds, the impact of the COVID-19 pandemic on treatment, on care, but as it was very clearly established around the mental health issues, the stress and things experienced by people living with thoracic malignancies during this time. And as Dr. Sheila has said, we should not forget the caregiver either, or their perspective on all of this. So we really do need to try and have a more, holistic approach to everything, and ensure that any of the issues or problems experienced by people living with these diseases are given the care and attention that they need when they need them during the care pathway. So I think really important things come out of both the presentations today and the discussions that we've had as well as part of this session. So with that, I'd like to thank all the presenters who took part in this today, and I'd like to thank everyone for attending, and I hope you enjoy the rest of the WCLC 21 meeting. So thank you all so very much.